Pleasure to introduce a colleague and friend, Dr. Mike Pitt. He's an associate professor of pediatrics with us here at the university. He's the fellowship director for hospital medicine. He's an associate program director in our residency program and the associate chair for faculty development. He graduated from Johns Hopkins School of Medicine and completed his residency at Northwestern. He's led several multi-institutional education projects, including being the co-creator of Simulation Use for Global Away Rotations, also known as SUGAR, which is a free global health curriculum which is used to prepare trainees for global health work at over 200 institutions. A winner of multiple education and mentoring awards, Dr. Pitt specializes and has studied several non-traditional forms of education and has published over 70 peer-reviewed papers and book chapters on topics ranging from game-based learning to the study of jargon at the bedside. As many of you may know, Dr. Pitt is also an award-winning magician, having performed nationally for over 25 years, including for several Fortune 500 companies. He's taught nearly 3,000 pediatricians how to leverage their skills used by magicians for centuries to improve rapport and ultimately diagnostic yield with patients at the bedside. So without further ado, I'll turn it over to Dr. Pitt.
Hi, everybody. Thanks for having me. I apologize if you hear any kids in the background. They're getting in the car. If you hear a dog bark, please mute yourself because we don't have a dog. I'm excited to give this talk today. This is building off some work we've talked about before in communication, but really focusing on something that is so prescient right now around the internet and misinformation, and how we as providers can play a role in dispelling myths and stopping from contributing to them. I have no conflicts of interest in this space. I think the real theme of what I get excited about talking about is we tend to talk about the art and science of medicine, and then we just learn and buy textbooks and go to conferences to talk about the science of medicine and just look at this art almost as a binary, as you have it or you don't, or you're just good at this or you're not, or it's just, very personality driven. Yet we don't look at the science of the art. What is the art of medicine? I firmly believe it's a performance art, and a lot of that actually requires skill to continue to build. A surgeon has a complex procedure scheduled on her schedule for the day and may think, what's the approach I need to take? I might open a textbook and look at the different methods. Which is the approach I will take for this complex procedure tomorrow? Yet we often enter conversations that may be predictably difficult or common, informed consent, yet rarely spend the energy looking at that as a procedure and saying, what science, what skill can I bring to that? That's really what I want us to focus on today. And we'll do that by looking at three things: medical misinformation and our roles as providers to address it. So we'll look at the evolution of that from print, media, and the internet, and kind of address our role as providers and why it's important we address that misinformation. We'll look at strategies to communicate with patients about internet findings. So this is the patient comes in and says, but I found this on the internet, or maybe they don't even say those words. That's parenthetically implied as they ask a question informed by the internet. And then we'll own our space in this. So we're going to say, first kind of blame the media, right? Then look at how we can change that with advocacy. Next is, while the patient's finding this, how do we dispel it? How do we look at skills we can bring to that conversation? And then third is, let's blame ourselves. Let's say the reason many of our patients are going to the internet is because we confuse them and we haven't been either available or clear enough for them to feel they have an understanding to be able to have an action plan. So that'll be revisiting some of the work from a previous grand rounds on jargon, where we'll just go over some of the highlights of the work that Marissa Hendrickson, Jordan Marmette, and I have been doing. And then I have a secondary goal, kind of a sneaky, this is under the faculty development hat, is really by highlighting some studies that have done this work, what I've landed on as a research life cycle. In fact, when people would say, do you do research? Early, I would kind of forget that I did. I would think, I just am curious about things and I've asked questions. Research is for people who call it research, right? When it's pronounced that way, those are real researchers. And I want us to, as I go through some of the studies that we'll use to inform this, look at what I believe is that research life cycle. Something annoys us, something bugs us, there's a problem, which leads to curiosity, ultimately leads to a systematic way to scratch that curiosity itch and get to an answer. And what I want to make that fourth step, this will be a goal of us this upcoming year in faculty development, is not just disseminating our research, but how do we actually leverage it for advocacy? How do we make change from our research and get stakeholders to be involved? That does not happen just by publishing a paper. And so we're going to talk about that a little bit. And really, that's the life cycle: is annoyance, curiosity, research, change via advocacy. So you'll see these icons or emojis used throughout the presentation to remind us kind of what phase we were in with a particular question. So we have been giving each other advice as long as we could record anything or communicate. So we've been giving each other advice on how to hunt before we had written language. Anybody in a family knows that it is often a unidirectional path of advice, especially when you become a new parent. I remember when we had our first baby, being in the basement of my in-laws' house with my wife and going, you know what I just realized? We don't have to take their advice. We don't have to argue everything. We can just say, yeah, that's a good idea, and just move on. That was one of the most freeing moments of being a parent in a basement in the mountains of Georgia. That advice has moved up from books, what to expect when you're expecting, to online. Particular category, thousands of what's called mommy blogs or parenting blogs, which is, our independent experts sharing our expertise. And I've read several of these, and there's often brilliant advice that's now becoming a common source of advice. In fact, my wife and I coined a term when we were first parents called momformation bias. And it's when we were looking for advice on how to do something, and we would just keep searching mommy blogs until we got somebody that told us that we were doing it right. And that is part of the problem we're going to address today. Before we dig into this internet, the Dr. Google, I want us to rewind, and I'll tell some stories about why I got interested into this. And we'll start with print media. So I remember in med school, you'd be in the waiting room of our clinics, and there'd be at residency, there'd be all the parenting magazines. And I would open them up in my continuity clinic in between patients and notice that many things we were telling them as AAP recommendations were not what was being told in the magazine, particularly in the advertising. A page like this, and I could flag multiple images or products that violated AAP's recommendations. So I remember that moment during residency being a moment of annoyance. This is a place people are turning to for kind of expertise, and they're getting bombarded with imagery that contradicts that expertise. So that led to curiosity. So the simple question was, what percent of advertising for products and for children in the leading parenting magazines contradict messages that are recommendations of the AAP? So walk with me, and I'll take you on that journey. So here's how we did it. So first, I first did this study when I was a resident in 2009. As part of a research journey, I didn't have much mentorship, and so didn't know how to publish it. And by the time I was at a place that I could publish it, the data was old. So I partnered with a resident when I came here, and we repeated the study and ultimately published it in 2014 data. But we looked at the two leading parenting magazines, which had 73 advertisements per issue, over 1 billion ad exposures per year. And lots of studies shows that repeated imagery normalizes, and especially if it's in a place where one is looking for expertise, endorses what is being told. So we reviewed all advertisements in the two leading issues for 2009 and 2014. And we coded images for children to whether or not they violated published AAP recommendations. An example, if a child is riding a bicycle but not wearing a helmet in an ad, regardless of whether or not it's an advertisement for a bicycle, that would violate a recommendation. So we flagged those ads and found that over 2 years, in this bottom right corner, that the average was 1 in 6, 15%, or 16% of the ads in magazines contained at least one violation of an AAP recommendation. This didn't change much over time or over the journal. There were certain categories that had some changes, particularly as certain AAP recommendations emerged or were modified. Over half, almost 60% of the categories depicted in these imagery, if they were parents took on that advice, were for potentially life-threatening categories. One of the ones that got the most kind of pickup was advertisements that just show a cute baby. Maybe it's an ad for formula or for detergent, but the baby's asleep in an unsafe position. And again, it reinforces, just pay attention to this. When you see a crib in a television show, it's bumpered with stuffed animals. So, it's very rarely the single sheet, blanketless crib that we describe. So publishing this kind of led to some further discussion, some future work, and moving into not just ending with a paper, but pushing for advocacy in then the follow-up recommendations on the sleep. Citing this work, the AAP made an explicit statement that the media and the manufacturers should follow safe sleep guidelines in the imagery they use in advertising. So now that itself was an AAP recommendation. So that took us to my advocacy emoji, which quickly turned to annoyance, because the next curious question we asked is, I wonder how the AAP releases a policy statement. They also release a press release. So our question was, I wonder how the press is covering this press release, and whether or not in their own coverage they are actually abiding by the rules. So at this point, I involved another resident at the time, Pallavi Kamra, who was a chief resident at the time, and we looked at all the press releases, places that published the press release of the AAP's new sleep recommendations. And then we said, was there an image, and did that image comply with these new recommendations? So there were 44 pickups in the national media from the AAP sleep recommendation. Almost all included a photograph, and of those, almost all were a photograph of a child or an infant not being held by an adult in a sleep environment. And you guessed it, 2/3 of the photographs of the press talking about the recommendation for the press to depict safe sleep recommendations violated that own recommendation. So this advocacy still has room to go. Interestingly, when we were presenting that work at the AAP conference that year, we were interviewed by a journalist who wrote, Tara Hale, who wrote this book called On Science-Based Parenting. She said, gosh, you know what drives me nuts? I've always been wanting to do a study on is the way vaccine imagery is depicted in the media. So this talk really has many things that are going to be relevant for the coming time ahead. Why is it anytime there's a study saying get your kids vaccinated for the flu, they show a child getting tortured? And they actually capture the moment of a screaming child. Now imagine you're a parent, or they show a needle that's so long that if your fear is of needles, this is not going to do much to reinforce the message of the article. And so we started looking, well, are there images that could depict vaccine imagery in a less kind of fear-inducing way, especially when coupled with an article that is promoting vaccination? And so we found certainly ones where the child, many times, this is how actually my kids have reacted to shots, not screaming, so capturing other moments where the child is engaged or seeking comfort, or even post-vaccination. If I was doing an article on urinary tract infections, I don't need to include a picture of the catheterization. Right? There's the toxic, scary moment of the procedure might not need to be what's used to do it. So actually, showing a healthy child, showing a child with a Band-Aid smiling, could be that work. So again, that led us to a question: how could we capture this in a research question? What could we do? So a couple residents and I partnered with Tara Hale, and we looked at internet search terms for 3 major vaccine stories: Disneyland and measles, autism and vaccination, and then a repeated annual story of flu and vaccination. And we found that upwards of 30% across of the pictures used, the majority were neutral, kind of didn't either just showed a person, which was great. But about 30% had that negative kind of fear-based imagery. So that was published. And then shortly after, the AAP reached out and partnered with a magazine and actually published a free bank of pictures that journalists could use for vaccine media coverage that don't depict kind of this fearful, scary moment of vaccination. So again, not ending with publication, but finding a way to elevate that into an advocacy or change. I want to share one more example that I think was in that as we move from kind of print into video consumption. So I'll never forget sitting with Margot and Phil, both a chief resident and now a current resident, at the time was a med student. And we were sitting in my office talking about the show 13 Reasons Why, which was one of the most popular shows on Netflix at the time. and depicts the graphic suicide of its lead character. And her suicide after her death leaves behind an audio tape of the 13 reasons why she died by suicide, and really becomes kind of the hero of the story through telling this death post-mortem. And we were saying, gosh, I'm hearing anecdotally in the hospital patients reference this. Is there a way for us to capture the danger this is doing? That led us to be curious as we started to look into WHO and CDC guidelines that explicitly talked about copycat of death by suicide when it's depicted graphically in the media, and explicitly states do not show the graphic death in fiction, do not describe it in detail in the media, because it's known to create a copycat effect. So we struggled with not being a researcher that thought, well, could we look at national trends and look, we thought, well, what could we do in our own institution? And so we looked at Epic and we asked for a data set for the Fairview system of any time the phrase 13 Reasons Why was documented in Epic. We also asked for Stranger Things, which was the other most popular show at the time, as a control. And so we then did a qualitative analysis of the times that it was actually captured in the chart to say, why was it written down? Was it just person likes this show? Was it in the context of a suicide attempt? And in our system of just youth in the 6 months surrounding the show, so again, this was our study question, was looking around there and using that grounded theory to analyze the chart. But in the 6 months surrounding the show, we found 63 documented references to 13 Reasons Why among 31 unique patients. Think about the underreporting that is. Somebody had to actively choose to type that. 71% of them referenced the show during a presentation related to suicidality, and more than half of those said that the show had contributed to their suicide attempt, including patients explicitly stating that they had made lists of 13 reasons why, they had cut their hair to look like the main character prior to the attempt. This was pretty powerful. We published this in two journals, both the data set and kind of a call to action advocacy piece in Pediatrics. And then a few months later, the Netflix removed the scene from the show. So while it's a streamable show, the graphic scene was depicted. So again, how can we take that research cycle and add that step of advocacy? Often it's chance where the work led to that, and it didn't require the ground game. I just wanted to kind of highlight that potential pattern in research in this space. So we've moved kind of through how we get advice, through time. And let's move to the internet. About maybe 7 or 8 years ago, I read this book called The Filter Bubble. And it was really the first time I had heard that the internet is different for you and me. We could have exactly the same Facebook friends. And based on our search history and other things, what we've liked, we will see very different feeds. We could have different internet. If I Google voter suppression and Uncle so-and-so Googles voter suppression, depending on what we search, we will get different answers. And this is a problem. This catered to our filter leads to confirmation echo chambers. The author describes the filter bubble tends to dramatically amplify confirmation bias in a way it's designed to. Consuming information that conforms to our ideas of the world is easy and pleasurable. If anybody's seen the new Netflix documentary, The Social Dilemma, Tristan, the producer, talks a lot about the dopamine effect of actually getting that confirmation and getting that the way the algorithm is driven. And I remember one of the ways I would notice this was searching things. So this was a study that I did in a hotel room at PAS. I'd gotten a new iPad and said, I've always noticed that if you type something, you get 5 suggestions. Well, what happens if we do that for every profession in medicine? So we had a new iPad. We searched it in the incognito mode, which basically means it's not going to borrow any information from a previous search, though this had not searched anything in the past. And so we searched and looked for a Google perception score. So what Google search autocomplete says about medical specialties. Because we would get 5 suggestions and we would then code them, the 3 authors, as either strongly positive, our heroes, or strongly negative, are murderers, and then there could be something in between, are taking my insurance would be neutral, for example. So here's what pediatricians are: stupid, rich, in high demand, but we're happy with a question mark. So we did this for 28 searches. There were 134 unique suggestions. So we looked at every ACGME matching category, and there were 50 unique phrases. The majority were neutral, or the plurality, I guess, were neutral. But of those that had a slant, it was 45% were negative. And here's the full list. I'm happy to share it with people, but kind of highlighting some of the ones that are fun. Neurosurgeons are crazy, but they're also gods. Cardiologists are ageist, but they're also happy. And gynecologists are evil, creepy perverts, but also lucky and good and bad, according to Google algorithms. Again, pediatricians are stupid, rich, in high demand. Are we doctors? Who knows? And are we happy? Who knows? So again, this was a fun study, but really did identify the way people can interpret the world through the internet. And I think cardiologists are ageist is actually something worth reflecting on, that enough people have searched that phrase, that's a perception of a field, is something we should be actively fighting against. And again, I think we know this, that we are in this bubble more than ever, where we seek confirmation and people are shocked by the outcome of something, because I saw Mike Lindell, my pillow guy, saying it's impossible that Biden won Minnesota because everybody I know was voting for Trump. Stick to making pillows, not political punditry, because that logic is quite flawed. So let's move on. I don't want to only talk about the negative here. There are positives in the medical space for social media use. So one, an ability for a group of people to come together and identify a drug's side effect, or in this case, the breast implant, awareness of this particular breast implant causing symptoms, was through social media and groups kind of having a space to come together on that. Many places say, well, let's actually partner with these. How can we use this for good? How can we leverage and stop the misinformation and really use this? And I think that's something we are going to have to acknowledge our role as providers and how to do that. Christina Crone who's in Med Peds, has been leading work with Nassim Quadri on how to actually identify misinformation and teach medical students to actually, specifically in the infodemic of misinformation and the pandemic, of how they could actually disperse them as an army, essentially, online to systematically dispel those myths. And that paper was just published in Academic Pediatrics. So I think we've all done this, right? Especially in COVID. I think this number was pre-COVID, that 8 in 10 people have searched for their health information online. I guess 2 in 10 people were asleep when they asked the survey, because we've all done this. We've all been diagnosed with a cancer on the internet, for sure. And it's important, as we look at why we should care about this, why we should care about the fact our patients are doing this. At least it's reported that on major pediatric topics, we are still seen as the expert. Science can win here. People are spreading where they get information and how much they trust it. But our role is, how can we help drive that green line up and drive up what's trusted in the media by actually contributing to more honest reporting, et cetera. So we spend a little bit of energy kind of blaming the milieu. Let's move into the skill set of what to do about it. And I'm just going to peek at the chat mid thing to see if there's anything that I should address question-wise. Nothing so far except some compliments. Thank you. Okay, so let's move on to what to do about it. So strategies to communicate with patients. And this gets back to, how do we remember we have a skill set? Communication is a practicable, improvable skill. So let's look at it. Once my mouse clicks. I thought if anything that I looked up to prepare for this made me long for a simpler time. The most searched health questions in 2020, of course, all related to COVID. This is going to kind of break your heart for a simpler time. 2019 was how to get rid of hiccups. That actually speaks to me. That's why I wanted to be a pediatrician when I was a kid. I wanted to come up with a cure for hiccups, and this nudged me that maybe that'll be my next grand rounds. Okay, so the framework that I've come up with for this, kind of looking at the media, of saying of the research here, what are 3 approaches to responding to patients regarding their internet-fueled questions? And we're going to use the framework WWW. We'll start with wait. And what I mean here is resisting the initial need to correct, and looking at, how do I leverage empathy in this moment, and not necessarily focus so much on what they're saying, recognize that the reason they're saying it is probably a need for some empathy. And that is something, as somebody that doesn't consider themselves remarkably naturally empathic, I have learned to embrace that as a skill. And certainly, if you fall off a ladder and you're my neighbor and I see you fall off, I'm going to run, and I'm really good at empathy in the real world. But you come into the hospital and I might say, did you hit your head? On a scale of 1 to 10, what's your pain? Do you have nausea? I might forget oh my gosh, that must have been terrifying. So wait, check yourself and recognize this is an opportunity for empathy. They are not trying to show out that they're smarter than us, that they don't trust us. They are doing this for a reason, and we'll get to that shortly. Really pause and consider what emotions are behind that healthcare search. Fear, uncertainty, and how can your response actually address that before it responds to data? So again, empathy is a skill. One of the studies I love in this space looked at when we used empathic statements with a patient, our visits were shorter. So this is not a time suck to be empathic. It's actually a skill that can save you time. And then the best study I've seen on this looked at people that came to their doctor's office for a common cold symptoms. They audio recorded the transcripts with permission, coded to see if the providers had used an empathic statement. And then they looked at both neutrophil response in the nose as well as self-reported duration of symptoms. Those that had one empathic statement had statistically significant shorter duration of cold and much greater increase in immune response to fight that cold. If there was a drug that did that, it would be on the news. This is a skill that you can apply to help shorten your patient's symptoms today, is the way we demonstrate and use empathy as a skill. I'm going to show a video now that shows this, a 2-minute video. So make sure you come right back.
It's just, there's all this pressure, And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
No, see, I don't think that is what you need. I think what you need is to get the nail
See,
out.
you're not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. All of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't...
Try to sleep in. That never gets old. And I think what it reminds me of is we go into medicine because we are fixers. And we see nail. I've got a tool. I'm going to hammer it in, or I'm going to take it out. And we forget the art of medicine. And that moment of that must be difficult is a powerful tool, just as powerful as the back of the hammer to get it out. I think the work that got me interested in this was the work out of the Cleveland Clinic that we brought here as the communication course many of you have taken. And just a reminder, in that empathy is skill phrase, they put out this framework, SAVE, of saying, add this to your toolkit like the hammer. Maybe it's offering a support statement of, gosh, I'm glad you brought that up. I'm glad you came to the right place. I'm glad that we could talk about that. Acknowledging, gosh, this has been difficult. That must be stressful. I could see why many of my patients have. Validate, normalize that response is real and justified. And then some people are good at this. I'm not as good, but emotion naming. So you just say, gosh, this seems to make you scared. It seems to make you angry. Giving them an opportunity to name that emotion. So what would that look like in this weight frame? So you have a patient that says, I was reading an article that said if I fed him artichoke hearts, his PDA might close faster. And so our gut reaction might be, what are they talking about here? I'm impressed that you found the time to research this. It's been really, really stressful. That's kind of an acknowledgement, support type statement. Wow, it's obvious how much you care about this PDA. Again, you're not validating the science, you're validating the emotion behind the search. I can see this PDA makes you nervous, and that can be your in to discuss it, rather than that's ridiculous, there's no reason artichokes, blah, 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 right? It's wait before you get into your science. Pause. Data is not the answer to the first part of the question. Now let's get to the what. So we've waited. What? We're going to explore ideas. We're going to be curious, and we're going to be open-minded. So let's get to the what of what they're talking about. The elephant in the room might be, part of the way we do this is just acknowledge that lots of our patients do this. So don't wait for a patient to say, I found this, can I ask you a question? As you're reaching on the doorknob, address it. A lot of my patients go to the internet for ideas, for things they think might help them with what's going on. Is there anything you came across you'd like to discuss? That burden lifted of not embarrassing themselves, because if you don't do it, the internet wins. They're just going to hold on to that, and you didn't talk about it, but you also didn't debunk anything. So this should be a question we ask our patients, is giving them permission to share what they found or what ideas they've come up with. So it creates a safe zone for them to do it, and it also validates that search. My favorite moment is when you say something and one of the parents kind of elbows the other parents and says, like, see, I told you that wasn't a dumb question. Those are powerful allied moments in the physician relationship with the patient's family. So seek those out. This is a manipulative way to get that to happen, by asking that question and then ultimately bettering inform your care. Being curious. So waiting, recognizing the emotion and the emotional response. When we're into the what, it's not tell me what it was. Oh, you said this and I'm done with you. It's being curious. So what did you find? Often the act of having them try to explain it, they will go to themselves. I guess that kind of sounds ridiculous. Getting them to say something out loud. Tell me what you found. Showing that you're curious and in that non-judgmental space initially. One reason, maybe they know something you don't. Now, I'm sure we can all reflect on times a patient found something on the internet that was right, that I didn't know. And my friend Paul Kleinschmidt tells a story of a patient that said, well, when he asked the internet question, he goes, I think maybe I have scurvy. And that led him to go down this path. Why did he think that? What symptoms? And ultimately, this guy had a profound vitamin C deficiency. So the patient was right. And one part of being curious is being open-minded that they can be right. Not so open-minded that our brains fall out, but open-minded enough that we're ready to be wrong and ready to learn. And we should be. We should be able to compromise without compromising our beliefs, both in how we engage in a plan around what they find, but also in our posture of listening to what they have to say. So we're going to wait, seek emotion that is behind what they're doing, and respond accordingly with empathy. We're going to seek out the what with a curious, open-minded posture. And then we're going to get to the why and use this understanding to negotiate. So whereas the wait is trying to kind of guess the why and understand it, the why is a little more explicit in seeking that out. Because all of these, is it worry that's driving this? Is it a sense of control of wanting something that can be done now? Is mistrust? Was it just a chance encounter that came across their feed, which of course now we're learning is rarely by chance? Don't let something that doesn't matter cause you to lose something that does. So you might hear something, and before you're going to pick your battle and say, you know what, is adding beets to the diet going to change much, or whatever the thing is that they found? And that's where you don't have to endorse it. You can say, I think as long as we're following this path here, I think it's certainly worth trying. That can be validating. Let's also remember, placebo effect is something we rarely get to leverage intentionally. So if, again, open-minded, maybe there's something to the beets, and if not, if it's not harmful, don't negotiate it just because it's not scientifically backed up. You can be open to leveraging that negotiation. You've heard me say this before, but is a word I'm trying to strike from my vocabulary. It undoes the first part of a sentence. I think you're doing a great job on this rotation, but what I'd like you to do differently is immediately takes away the power of the first part, as opposed to just replacing it with a period. I think you're doing a great job on this rotation. One thing I'd like you to try differently tomorrow is very powerful. I think about this at the Thanksgiving virtual dinner that we'll all have with family members. Gosh, I hear what you're saying, but, as opposed to, I hear what you're saying on that. Here's why I think differently. Very powerful to take but out. And so this can be powerful when we're having these discussions with patients about their internet finding. I can see why you'd think that. Or I can see, gosh, I can see why that would, yeah. But the reasons versus, gosh, I can see why you'd think that. The reasons I feel a little bit differently, very different, not confrontational, doesn't invalidate their feeling or thought. And then I remember when Paul Offit did the Wanamaker lecture a few years ago, he was telling us we've got to be better at using story rather than just data when we share information with patients and the public. Because we go out and say, vaccines are over 99% safe, and we so stuck to the data that people hear a number as opposed to just saying vaccines are safe. They prevent preventable deaths, owning this. And I think we should not be afraid to fight story with story. So if a patient is saying, gosh, I read this story about this person on the internet who X, Y, or Z, that's an invitation for you to use anecdote from your patient experience to add another story to counter that. And certainly not making something up, but using anecdotal evidence. Gosh, I had somebody that tried that and X, Y, or Z, or trying to bring them back to the middle with story. Don't be afraid to fight story with story. And certainly I'm not there's a lot of this out there in that vaccine resistant space. Share your worry. We are often afraid to use emotion words. Gosh, it's pretty powerful if your doctor is worried about a choice you're making. And that can be what I can see why I would want that to work. Here's why I worry about it. That phrase, hearing your doctor's worry, can be a powerful thing. Here's what worries me about switching to goat's milk. Not, here's what studies have said about switching to goat's milk. And it's just this. You're going to get to the study, but make it personal. Don't be afraid to do that and leverage the relationship-centered communication. Another W to add in this is just wish statements. These are easy ones. Throw this in your thing. Gosh, I wish there was something that worked that well. I would use it for all my patients. That is not belittling their find. That is stating that, yeah, I would wish that would be the case, and I can come alongside you as we look for a better plan. Wait, seek the what and be curious, get to the why, have them kind of understand why it is, and then you can use that in your negotiation. So I want to move, again, we've talked about the media's role in this and kind of misinformation and why this comes our way. We started to say, well, how can we address that? What are some skills we can bring to the table in the communication space? And I'm going to use this last 10 minutes here to just recap some work from previous work we've talked about owning the fact that one of the reasons our patients are confused is because we confuse them. So if we're going to say we should look at the why are they going to the internet? Why are we losing share in the market of expertise? And a part of it is because we don't explain things well. And we say things, if you've seen me do the jargon grand rounds, I do a magic trick and then I teach you how to do it, but I use magician's jargon. And you're not able to do the magic trick at the end of the explanation. And I say, if you can't do the magic trick, you are non-compliant. I just told you in perfect English how to do the magic trick, and it's your fault, is the way we think of this with jargon, that you didn't understand. We need to diagnose our jargon oblivion. This is the work Drs. Hendrickson and Marmette and I have been really working on the last couple of years. Looking at Osler's quote, this is our single greatest job for the art, there's that word again, for prevention and cure of disease. The person who translates the hieroglyphics of science into the plain language of healing is the most useful. Kind of the father of modern medicine, driving this point home. So let's quickly go through those 7 categories. So 1, classic sentence. Your jaundice, which is due to elevated bilirubin, could be caused by cholecystitis. We're waiting for the radiologist to read the abdominal ultrasound to see if you may need a cholecystectomy. When we think of jargon, language that is understood by a select group and often used as a shortcut, I'll point out that Webster's definition adds and is often pretentious, which I think sometimes we weaponize the pretension of jargon when we don't have a good answer. But we all think of medical terminology, words we definitely learned in medical school, disease names, tests, procedures, etc. So that's pretty common. It can sometimes be our profession. Less than half of women in a breast clinic waiting room knew what an oncologist was. They were there to see an oncologist. So even our own titles can be confusing to people. Acronyms certainly play a role, or abbreviations. EKG for your MI, CBC, NPO. NPO is something we often then spell out and say, well, nothing by mouth. First of all, those aren't the same letters because it's Latin to English. So that's confusing to patients. Nothing by mouth is a rather strange way to tell somebody not to eat or drink something. Who's saying to somebody, so it's lunchtime, what do you guys want to do by mouth, right? We try to simplify it by spelling it out, but certainly make it more complicated. Same thing if we say LFTs and say liver function tests, both are jargon, right? So simply saying it out doesn't get us there. Medical vernacular is a category. These are words that are familiar to people. Maybe they've heard febrile or stat or sepsis, but they're not understood when it's been studied. And so they've heard electrolytes, but they don't know what it is. They might know a body part, the spleen, but they don't know where it is or what it does. And this has been, again, less than half of people in remission could define what the word remission went even close to an accurate definition in a cancer population. I think an easy one to audit is unnecessary synonyms. We take a word that the entire universe has a shared understanding for, and we complicate it with medicine really purely for pretension's sake. Why is an arm an upper extremity? In fact, it leads to more chance for error because I have lower extremities I could be confused with too, whereas I'm not going to confuse an arm or a leg. I still resent ophthalmologist notes that use the Latin abbreviations for right or left eye, as opposed to just telling me what eye it is in English. That's a chance for error. It's a relic of pretentious education that we can eliminate and not complicate our patients, and certainly does not lead to a shortcut if I take the wrong eye out in a surgery. Oral intake, eating, instead of eating and drinking. Oh yeah, he's not ambulating, but he's been walking, things like that. Fracture. And I think of, as an English major, I think of the quote from Mark Twain: "I never write metropolis for 7 cents because I get the same price for city." The next category is words like this: "I don't appreciate any focal tenderness in your abdomen, and the CT scan was negative." These are words that are medicalized English. Whereas the last word, we have an English word and we give it a synonym that everybody could have understood. Now we have a word that we co-opt, hijack, give a new definition to, that's often an antonym of the word, and forget that we ever used it in plain language. So we say "I don't appreciate" to mean I don't appreciate a murmur. I don't hear something somebody else might see. Whereas the rest of the world uses it to say, like, "I don't appreciate that you did that. It hurt my feelings." You know, when my wife was looking through family pictures and she said, "Gosh, my mom's gained weight," I looked at the picture and said, "I don't appreciate that." Saying I look at it and don't see she's gained weight. What do you mean? I don't appreciate that. Why don't you appreciate it? What do you matter? They were on vacation. You know, these are moments we do with patients all the time. Discharge, admitted, precautions, impressive, words that mean different things. Progressive. It's not a tumor. We think that everybody would understand what this means. 48% of patients thought that was good news because progress is good. In English, progress is good. So tumor progressing must be in the right direction. That's a problem. No place summarizes this better than negative and positive, which have the opposite meanings in medicine as they do in the rest of the world. Positive is good. Negative is bad. Except in medicine, positive is bad. Your lymph nodes are positive. The MRI was positive. The test results were negative. These are things that, when have been studied, 30 to 50% of patients think the test results were negative is bad news. That is an easy fix. One of the ways I hinted at this before, not being afraid to use emotion. Give your tell. You don't need to keep a poker face when you're telling results of a test. Make them understand it through your lens. Gosh, I was happy to see that. Gosh, this worried me a little bit because. That way, when they're telling their family or interpreting it, they can say, "My doctor was happy to see." They don't have to just say the natural killer cells. You know, they can actually interpret the emotion. And I found a nice strategy is using the patient's name in this Mad Lib. So the test showed me that Sarah does not, the blood work showed me that Sarah does not have an infection, which I was happy to see, is very different than the blood work was negative or the culture was negative. Or, and again, if I say Sarah, I can't say the CAT scan showed me that Sarah was normal. I could say negative. I could say the CAT scan showed me that Sarah did not have a stroke, which was great news. So using the patient's name is both personal, it can also be an audit and check for yourself. 2 more categories before we recap and pause for questions. So euphemisms, jargon that we intentionally soften the blow because we don't like how it sounds, either because we don't want to say pee or poop as pediatricians, and so we use words like micturition or voiding and things that patients don't understand. Spots and shadows on the x-ray where we don't want to create fear, but it's been studied that it actually creates more fear. And certainly we know that if you don't say death or died when you're talking about it, is not heard. The euphemism does not land. Bugs. How many times has somebody tried to give a euphemism for an infection by saying bugs in the urine or bugs in the ear, to then have a patient ask about the insect and how they got the insect. And if they didn't ask, they're thinking it, and that's even worse. So recognizing euphemisms can cause problems too. And then the last space I think is actually really worth reflecting on in this new open notes era, where we're moving to reporting our documentation in real time. Things that we might not be doing on purpose. It's just our learned initiation jargon or just the way we're taught, that really, if heard by a patient, would sound quite judgmental. Non-compliant, denies, chief complaint. I mean, complaining is a pretty obnoxious way that we are taught to talk about a patient's presenting symptom. So these are things that are going to work their way in our notes. Like, what do you mean I'm complaining? Denies alcohol use is one of the leading reasons in the open notes era people have changed providers, because they said, I've been sober for 15 years and he keeps saying I deny alcohol use. What does he think I'm lying to him? You know, these are words where we don't say they deny cancer. We often hedge it when there's a little bit of that judgment. Failure to thrive, failed cancer treatment, which puts the onus, lost their battle with cancer, is something. There was a New York Times op-ed piece about this a couple years ago, about how that framework really felt this person who was dying of cancer feel like they weren't doing enough. So just recognizing our words matter. Marissa and I published this framework in Journal of Graduate Internal Medicine. And then Jordan and I partnered with 3 med students that have a paper that's in revisions at Hospital Pediatrics on kind of what this looks like to apply this framework at the bedside in a real-time audit. So the point of revisiting this, one, is the educational best practice of not just hearing something once. Space learning, let's bring it back and kind of reprime ourselves. And 2, this fits with all of this. If we did a better job explaining things, then we wouldn't be having to go to the internet and looking for alternative explanations. So own our role in this misinformation loop. That was our goal for this morning. We got 10 minutes left for questions. I love working with you guys. Thank you for having me. And then again, just this reminder that let's find a way to get these things to the next level. In one of our faculty development efforts this year, we'll be empowering our researchers to do just that, how to get it beyond the paper. So there'll be peer-to-peer sessions on that, as well as additional points within the PQuad framework for when that happens. So with that, I will pause for questions, and thank you for having me.
I can read them out if you like, Mike, or you can probably take a look. It looks like we have a couple coming in from a student, potentially. Frederick Blaisdell asked about if you've ever had an experience where a patient is doing research for their condition and found a treatment, drug, or study that was credible or new before you learned about it.
Yeah, all the time. And that is not a judgment on our own knowledge when that happens. It's the reality that the medical doubling time, I don't have the exact number in front of me from a previous presentation, but when we look at the time it takes for the amount of medicine to double, 100 years ago, it was 150 years. It is now under 3 years. No, it might even be 72 days. It's the amount of kind of published work that could be knowable. And so it's impossible. And so rather than saying how I have to know everything and being defensive if somebody knows something, that is where this WWW framework of being open-minded can absolutely lead to a better outcome for your patient. So absolutely don't take that as a judgment on your knowledge. Take it as a judgment on a reinforcement of your ability to create a relationship with your patient, that they're comfortable telling you that without feeling that you'd be defensive. I see a question here. Any advice for how rising students can change the way language is written and communicated while we still get graded or judged by physicians who have done things the same way for so long? This is the tension in this work. So part of the reason we're talking to faculty is that take the middleman out of it. When I'm in rounds with a patient, if they say to me, Jack is afebrile overnight, his erythematous rash is no longer tender or desquamating, and the family's looking like this, I would rather eavesdrop on their conversation to Jack. And I can translate using the $200,000 in medical debt, into medicine if I want to, but let's speak the language that's in the room. So one is model it. And so I think as students, one of the ways you can say it, we tend to be pretty open to what's being taught now. You are now empowered to say, we're really being asked to actually communicate in plain English, so we don't have to toggle back and forth. That said, you're not going to call a surgeon and say, Tommy, and I have a consultant, and Tommy has a tum-tum ache. It's real owie. You need to have that precise language. Precision does not always mean jargon, however. So one is model it. Two is be curious. Like this is one of the things we're looking at. And what's your take on the role? Because I think a lot of us use jargon because we forget we didn't know that terminology at one point. Once you're aware, my gosh, patients don't understand that. If you still want to be telling things to patients that they don't understand, then go up the chain and report somebody for that. That's malpractice. So the reality is, if most of us should be open to that, and I think that modeling can come both from peers above and below. Not a question from Sue Berry, but a suggestion. In a rare disease genetic counseling, we come prepared with reliable sites and especially parent support groups. Yes, this needs to be something in our arsenal. Not, yep, you're on your own. How do we equip you with things? And maybe that requires doing some research of what is a resource to share. Many of you know I'm on the board of an organization called Jack's Basket. This is to come alongside families and celebrate Down syndrome rather than share it as bad news, objectively bad news, a bias we often bring when we talk to patients. And a big part of Jack's Basket is empowering them with local resources that have been vetted by the medical squad as well as families with Down syndrome. So it's a great point. Other questions or comments or examples of any of this work we've had?
Jeff Louie had asked something in the chat, but it was a little while ago, just about that filter bubble, and was curious about if you think that's applied across all social media platforms. So
yes.
YouTube.
So the answer is an emphatic yes. If something is free in social media, then you are the product. That's the frame. And you are only a valuable product if you are engaged with it and advertisements can reach your eyeballs. And so they will, I can't recommend strongly enough The Social Network. It's a documentary on these algorithms with all the creators of the work that's on Netflix right now. But you are the product. And so it is not an accident that you were chatting about something or searching. A perfect example of this is even the cookies into dictionary.com. So if I've been looking up symptoms for depression, and all of a sudden, or if I looked up the definition for depression on dictionary.com, I will start seeing ads for antidepressants, and in a disproportionate way. So we are being targeted, absolutely. And I can't do justice to what the documentary says. Jana, when adolescents go online and look for something up, I praise them for seeking information to improve their health and see it as an opportunity to teach, praise, health literacy skills. Yes, what's so important about this, how often do we do the opposite? Now, don't go looking on the internet. So that should be struck from our from our vocabulary. Is we should acknowledge that they're going to, and then to Sue's point, how can we empower them to do so in a more appropriate way? So Joe mentioned that. So giving them those practical, accurate websites. Gail Brotman, I find that when I want to explain physiology to learners at the bedside, I will then translate into English for parents, but they like hearing the technical explanations most times. Absolutely. And that's where the balance of what happens at the bedside versus what happens outside versus acknowledging that with a family. We incorrectly call family-centered rounds when it's family present rounds and they're eavesdropping on our conversation. So you're absolutely right. There's a place for the technical knowledge. We should know this, and we have to recognize that it's a toggle switch. I'm looking if there are any other questions.
I put a couple of examples of websites that I use frequently in the outpatient clinic. So the healthychildren.org is a really well curated that has lots of articles about things that come up frequently in the outpatient world. And then that CHOP vaccine education website is really excellent and has handouts for a lot of the most common, is it too many vaccines? What about mercury in vaccines? The kinds of questions that they often ask, and they're really well put together.
That's a great point. I see a couple really important points from Viv and Muna here about this with interpreter, when we're using interpreters across languages. And what I've learned to do is actually use the slower pace of the interpreter back and forth as a chance to be remarkably intentional with my words. So I have this luxury of some time to instantly reflect on what I just said, see if it needs some modifying because it was jargon laden or judgmental. And also, I'll tell you, open-ended questions with an interpreter, the interpreter does a double take because of how rarely we do it. Instead of saying bronchiolitis is, when I say with an interpreter, so what's your understanding of bronchiolitis? Often the interpreter kind of does a look like, wow, that's not usually asked. That is a judgment on us all. So couldn't agree more with those people. Oh, I'm sorry. Thank you. Social Dilemma. Bryce, don't watch Oh, you can watch it too. That's a movie. But Social Dilemma is the name of the documentary. Appreciate it. Yeah, this is a great question. Rashida, one of our residents, said, what happens when you talk to a patient in non-medical jargon and they ask to speak to someone else because maybe you didn't sound medical enough? This is a really, especially as one is navigating their professional role from learner to doctor, this is a challenge. And it is a toggle switch and a constant pulse check. This is what makes it fun. I've gotten to the point when a family says, and a nurse says, oh, that family's really angry. I think that's the same as a surgeon being told they have a complicated case. I like it. I like the challenge of that. And so it is a constant reading the room and saying, maybe this isn't landing. Maybe I do need to dial this up. Maybe I should ask how it is they like to be communicated with. There's a misconception that families, because there's a doctor in the room, want jargon, when often it's a one doctor of the relationship. And I've certainly been there when I was with my grandmother in the hospital and knew nothing about stroke management. And I actually wanted a little more of the dumbed down version. So part of it is that checking the pulse. I think that's a really important nuanced question.
I think that that should be your next project, Mike, actually, because I've had so many patients say, well, I mean, my doctor's really smart. I mean, I couldn't understand anything they were saying, but I'm really glad that they're so smart. So
Yeah.
I think this sort of like perception that our patients are expecting us to use language that they can't understand. And so if we don't, so some role for that, giving the lingo so they know we can do it. And that, I don't know, that's a
great nuance. Just to kind of highlight the importance of feedback from learners to attending. So up the channel. One of the best pieces of feedback I remember was, I'm blanking on the name of the resident, Brian, somebody several years ago. We left a room and said, I'm worried that family would say, wow, he was really smart. He's the smartest doctor I've ever seen, but I don't understand what he said. That was so powerfully convicting to me to think about, do my spiels show off? Is it just a lot of stuff that's not being absorbed, or is it actually communicated in a way that's understood? So that was a career-changing moment for me. I think that is a really interesting thing to reflect on. It's 8:30. I want to respect everybody's time. Thank you again for having me. Hope everybody stays safe on roads.
Thanks, everyone. Have a great day.